Hello everyone. Columbia Global Centers Mumbai, in collaboration with the Herbert Irving Comprehensive Cancer Center, welcome you to the second webinar of Screenings That Save, Detecting Stomach and Pancreatic Cancers. I would now request Dr. Ravina Agarwal, Director, Columbia Global Centers Mumbai, to please begin today's panel discussion.
Thank you, Manisha, and welcome everybody. I want to tell you a little bit about Columbia Global Centers Mumbai. The center is part of 9 global centers of Columbia University and was established in 2010 to promote cutting-edge research, knowledge exchange, and dialogue for addressing some of the most pressing challenges of our times. I welcome you to today's panel discussion, Detecting Stomach and Pancreatic Cancers. As a part of the center's commitment to promote cancer research and awareness in India, we collaborated with Columbia University's Herbert Irving Comprehensive Cancer Center and launched Screenings That Save, a seminar series that focuses on the importance of screening practices and diagnosis in early detection and prevention of cancer. Today's panel is the second in that series. November is the Global Stomach and Pancreatic Cancer Awareness Month, and hence we organized this panel discussion to support that spirit of raising awareness on the issue. A stomach gastric cancer is the 5th most common cancer in India and the world, and the 3rd leading cause of cancer deaths worldwide, following only lung and colorectal cancer in overall mortality. But 1 in 12 of all oncological deaths are attributable to gastric cancer. Despite such alarming mortality rates, gastric cancer remains one of the most behaviorally influenced and thus preventable of major cancers. Pancreatic cancer, on the other hand, is the 4th leading cause of cancer-related deaths globally and also remains as one of the cancers with the poorest prognosis, with an overall 5-year survival rate of about 5%. In today's panel, our panelists will talk about the trends in stomach and pancreatic cancer in India and globally, and discuss the challenges in the treatment of both these cancers during the pandemic, and suggest individual and population-based diagnostic measures to detect these cancers at an early stage, as well as suggest ways to prevent them. So welcome to all our distinguished panelists. My colleague Manisha Patak will begin with an introduction of our first 2 speakers.
Thank you, Dr. Agarwal. Our first speaker for the day is Professor Janine Jankinger, who's an associate professor in the Department of Epidemiology at Columbia University Mailman School of Public Health. She's a cancer epidemiologist who has been driven to understand how modifiable factors, molecular pathways, and related biomarkers may impact cancer risk and progression, particularly for rare but highly fatal cancers. Dr. Genkinger was recently awarded the Yusuf Hamid Fellowship to build research collaborations in India around nutrition and prevention of chronic diseases. Followed by Professor Genkinger, we have Dr. Gulam Manji, who is an assistant professor of medicine and director of medical oncology and translational research for the Pancreas Center at Columbia University Medical Center. Dr. Manji conducts translational research with the overall goal to develop new treatments for cancer. His focus is in gastrointestinal malignancies, particularly pancreas adenocarcinoma. He received the Young Investigator Award from the American Society of Clinical Oncology in 2015. He is the author of numerous key publications and has an issued patent. He oversees multiple investigator-initiated and sponsored clinical trials at Columbia University. I would now request Professor Janine Jankinger to begin today's session with her presentation. Welcome, Professor Jankinger.
Thank you for the invite. I'm very excited to talk today. So I'll be presenting this with Dr. Manji together, and we'll be discussing gastrointestinal cancers, focusing on both stomach or gastric cancers and also pancreatic cancer, and thinking about it from the lens of prevention, from the spectrum of primary prevention to where we think about what causes these cancers and how to reduce those risk factors, and then all the way to treatment and what can we do in that arena. So first, I just thought I'd orient the audience to the location of these cancers and the ones that we'll be focusing on today. Highlighted in yellow here is the pancreas, and it's deep in the abdominal cavity. You can see it's below the stomach and pressed up against the spine. And this is important to think about when we think and talk later about screening. As you can see here, we also are highlighting gastric cancers or stomach cancers too. And these are 2 important organs in the gastrointestinal tract. So to better understand these, it's important to understand the epidemiology of gastrointestinal cancers and sort of understand how common it is and what are the main factors that are causing the incidence and mortality of these cancers. So based on data from the International Agency for Research on Cancer, this is the cancer incidence in 2018 in India in women. I've highlighted in bold those gastrointestinal cancers. You can see colorectal cancer is the second leading cause, but the two that we're focusing on today are stomach, which is the 7th leading cause, and pancreas in women, which is the 11th cause. Overall, though, gastrointestinal cancers are one of the leading causes of cancer in females in India. However, it is still less than breast cancer incidence in India, even when combined together. In men, I again highlighted the cancers that are gastrointestinal, and you can see that stomach cancer is the 4th leading cause of cancer in men in India, and pancreas is the 12th leading cause. What's more shocking about these two cancers, as Manisha has already described, is the fact that these cancers are highly fatal. So when individuals are diagnosed with them, there is poorer survival, but we're hoping with better prevention and treatment that we will improve survival for those diagnosed with these cancers. Overall, gastrointestinal cancers in men are over 3 million are diagnosed per year. You can see that in combination is very large and has a huge burden on the population. So when we think about preventing cancers, there's 3 different ways we can try to prevent cancer and its sequelae and cancer mortality. First, we can think about primary prevention. Can we identify those factors that cause that cancer or factors that can potentially prevent those cancers? If we know those, we can better identify individuals who are at high risk for cancer. And we can also try to reduce those risk factors in the population and increase those preventative factors. So we need to better understand those, and I'm going to discuss both that for gastric and pancreatic cancer today. There's also secondary prevention that we can try to implement, and that is, can we develop effective screening tools, things that can be used to detect those cancers at earlier stage. And when we detect them at these earlier stages, the hopes is that we can treat them better and improve survival. And to do that, we have to think about, are there ways that we can have better early detection markers, and we're going to discuss that a bit when we think about gastric and pancreatic cancer. And Dr. Manji is going to talk a lot about tertiary prevention today, which is those effective treatments and what we know so far for gastric and pancreatic cancer. So let's first talk about gastric cancer and think about it in the context of what are those risk and preventative factors. To do that, we have to know a little bit more about gastric cancers. There are 2 main types, cardia and non-cardia. Cardia arise in the stomach adjoining the esophageal gastric junction, and non-cardia develop from more distant regions of the stomach. In general, the cardia ones are associated more with obesity and gastroesophageal reflux disease, or GERD, in Western populations, and non-cardia are more likely to be associated with H. pylori infection. There are a number of factors that are associated with gastric cancer, things like age, what I've also suggested with H. pylori infections, tobacco smoke, consumption of things like smoked foods, salted fish and meat, things like nitrates and nitrites, which can be found in meats and fruits and vegetables, along with a number of other factors. There's also some factors that have been suggested to lower risk, things like fruits and vegetable consumption. If you consume high amounts of those, we may lower our risk of gastric cancer. Having better food preservation techniques like refrigeration. And there has been suggestion that things like physical activity and even low dose aspirin use can lower your risk of gastric cancers. But there is some concern about aspirin use and whether or not it can also cause bleeding. When we think about screening for gastric cancer, In general, there are a number of statements out there that, screening can be effective if it's in high risk populations. High risk is defined as an age standardized rate greater than 20 per 100,000. India is not in this high risk population. It is more of an intermediate risk. One of the highest risk regions is in Chennai, where the rate is about 11.1 per 100,000. In high-risk populations, though, there should be a consideration for endoscopic screening if it's feasible within that location. And you can start implementing that in individuals over the age of 40. They can be considered and used in intermediate risk settings where they could be based on the local settings and the availability of these endoscopic resources. So in settings like high risk, there has been shown to be a benefit, and a high risk region is a region like Japan or South Korea, where if they do biennial or every other year endoscopy, you can, in adults age 50 years or older, and also do some existing upper GI series, that they do see a benefit in identifying those cancers earlier and also in reducing mortality. There has also been thoughts of, can we eradicate H. pylori if it's a driver of cancer? There have been some randomized clinical trials ongoing about this to see, A, does this work and is it effective? There has been studies to suggest that treatment of H. pylori may lower gastric cancer risk, but there are some concerns over eradicating H. pylori. It really, there has been a lot of thought that, H. pylori should only be eradicated during a certain time in an individual's life. And if we eradicate it early enough in someone's life cycle, that it may actually have detrimental effects. So there is some concern around this. So we still need to identify more clearly what these risk factors are, develop more effective screening, and look for things like biomarkers and other tools that may better identify these individuals earlier so that they can be treated better. And I'm going to switch over to Dr. Manji now.
So in treatment of gastric cancer, we need to think about it in different ways. We need to think about localized disease for patients with stage 2 or beyond, with either GE junction or gastric cancer. And the classic study was really done, it's called a MAGIC trial, in which combination chemotherapy, epirubicin, cisplatin, and 5-FU was done randomized to surgery alone. As you can see above, patients were randomized either to preoperative chemotherapy with 3 cycles, with subsequent recovery for 3 to 6 weeks, followed by surgery, again recovery, and then getting 3 cycles of ECF chemotherapy versus surgery alone. And as you can see in the red, patients that received chemotherapy fared far better. This is overall survival compared to patients with surgery alone. So for quite a, over probably a decade, this chemotherapy or some form similar to this combination chemotherapy was considered the standard of care. However, very recently in 2016, there was a randomized study with a different combination of chemotherapy with FLOT, which contains 5-FU, leucovorin, oxaliplatin, and docetaxel, was randomized and compared to ECF. And here again, patients received chemotherapy prior to surgery, followed by recovery, and then chemotherapy alone, with a median follow-up of about 43 months. And in this study, as you can see, the red line is depicting the FLOT regimen, which is a neo regimen, and patients did far better compared to ECF or ECX, in which the median overall survival was 50 months compared to 35 months. So currently, the standard chemotherapy in patients with locally advanced, potentially resectable gastric cancer is FLOT. I don't have time to discuss other combination treatments, which now are combining FLOT with either FLOT plus placebo versus FLOT plus pembrolizumab, so immunotherapy, to try and see whether combination chemotherapy with immunotherapy is advantageous. Another study, a smaller study, also showed that chemotherapy in combination with trastuzumab or Herceptin in patients with HER2-positive disease actually looked like the results were very, very impressive. However, it was not in a randomized study. That study is currently ongoing. So in patients with, stage 4 or metastatic or locally advanced inoperable disease, the standard chemotherapy is, combination therapy, including 5-fluorouracil in combination with oxaliplatinum, with or without trastuzumab, depending on whether you have a HER2-positive disease. And, in patients who have microsatellite instability or a high mutation burden, those patients would be eligible for immunotherapy, immune checkpoint blockade, such as pembrolizumab. So that those patients would be eligible for immunotherapy in the second-line setting if they were MSI high, or patients who have a high PDL expression of CPS score greater than 1 would be eligible for immunotherapy in the third-line setting. However, just recently in ESMO, there were 2 frontline studies that showed immunotherapy either in combination with chemotherapy or immunotherapy alone with pembrolizumab or nivolumab. And then we'll see after the data is published as to whether that will change the standard of care. I think that this is where I hand off to you for pancreatic cancer.
Yep. Thank you. So now let's talk briefly about pancreatic cancer. And first, again, we'll discuss what are the risk factors and are there risk assessment tools or scores that we can use. So if we think about pancreatic cancer, there are a number of factors that have been identified for to increase pancreatic cancer risk. The majority of these factors are considered moderate factors that moderately increase risk when we think about older age or being male. Smoking is one of the strongest and most consistent risk factors for pancreatic cancer, but the strongest risk factors relate to things like genetics and family history or an individual who experiences chronic pancreatitis. A number of these factors are not modifiable, but of the ones that are modifiable, things like smoking, maintaining a healthy weight, which can have impacts also on diabetes, and then also thinking about in the future about how diet impacts on risk. These are ways that an individual might be able to lower their risk for pancreatic cancer. Alison Klein published on developing a risk model to better identify those individuals at high risk, including a number of the factors I just described on the prior slide. The problem with these measures are because pancreatic cancer is so rare, a lot of these models, even though they may be well calibrated, are not very effective, useful tools in the population in general. We would hope for an AUC that is much higher. A value of 50 means it's close to chance. And we would want a score that's closer to 100% here. And you can see that these are not, so that they're not useful in the general population, even when we add things like genetic factors with non-genetic factors. So overall, these risk models are not that effective because the incidence of pancreatic cancer in the general population is low. The use of this in general populations is limited. But what about familial or genetic risk scores? Can we use those to identify people at risk? There was a model developed by Wang et al., which looked at the number of family members who had pancreatic cancer, as well as what relationship they were to them, were they first or second degree, and the age of onset. You can see that this score is actually getting better and closer to a value of 1.00, but we see that it still has a bit of a ways to go, and that we hope to improve on these models to identify those at risk. So secondly, we can think of, are there ways that we can screen for pancreatic cancer so we can detect it earlier? Currently, institutions like the US Preventive Task Force believe we should not, and they actually recommend against routine screening for pancreatic cancer in the general population. However, there is an international consortium, which is called CAPS, And there is a belief that we should be screening individuals who are considered high risk. Who is high risk? Those people who have first degree relatives of patients with pancreatic cancer that come from familial pancreatic cancer kindreds with at least 2 affected first degree relatives, or people who have particular types of genetic syndromes, things like Peutz-Jeghers syndrome, P16, if they have a BRCA2 mutation, or hereditary non-polyposis colorectal cancer mutation. So they're suggesting that those individuals should undergo screening, and screening can include what we call EUS, or endoscopic ultrasonography, and or MRI. However, the timing when it should be initiated and the frequency is still up for debate, and studies are ongoing about this. So it's hard to screen pancreatic cancer because it's a very rare disease. However, we still have to fully identify when we should be screening and how often, and which population should we be screening. And we have to better identify these high-risk groups. Can we do that by developing better screening tools, like risk assessment tools? Can we better understand what causes these cancers? And can we use, just like in gastric cancer, can we use novel markers in the blood instead of just imaging techniques to better identify those individuals at risk? And there's a lot of research going on in this area right now. And I'm going to switch over and pass this on to Dr. Manji.
So as Dr. Genkinger mentioned, the anatomy of the pancreas is really retroperitoneal. So most of the time when patients have these symptoms, the symptoms are actually vague. They're epigastric pain, back pain, and the median age of diagnosis is in the mid-60s. So many times patients are given PPIs for reflux or given some analgesics for back pain. And it's unfortunately not until the disease is advanced that it's actually diagnosed. So the way that we really think about staging and treatment of patients with pancreas cancer is really looking at involvement of arterial or venous structures. Basically, what happens is that exactly in the resectable setting, you have no arterial or venous involvement, and that's when patients can technically go straight to surgery. However, as you go higher up, when you have distant, the other extreme is a distant metastasis where you have unresectable disease. So any patient who has disease that has spread outside the pancreas to another organ, such as the liver, the peritoneum, or the lung, surgery is really contraindicated. In about 30 to 40% of the patients, the disease presents itself such that it has involvement with some venous or arterial structures for which chemotherapy is needed to downstage the tumor. So here's a triple phase CT scan of a patient where you have the pancreas smack in the middle. So the pancreas tumor is actually outlined in purple. You have the common bile duct in sort of greenish gray, and then you have the superior mesenteric vein in blue and the superior mesenteric artery in red. So since there is abutment of the tumor near the SMV and the SMAs, particularly in the SMA, you need to give neoadjuvant, meaning chemotherapy prior to surgery, to move the tumor away from those vessels such that you can have a negative margin. Once you are fortunate enough to go to surgery, there are multiple clinical trials that have actually looked at which chemotherapy and whether chemotherapy after surgery for 6 months is beneficial. And most of the clinical trials basically say that is the case. And I'm going to discuss the most recent clinical trial, PRODIGE-24, in the next slide, which compared FOLFIRINOX. So it's going to be in the bottom. So the next slide will discuss that clinical trial. So we'll move forward. There it is. So where 493 patients with either R0 or R1 resection were randomized to either gemcitabine alone or modified FOLFIRINOX for 6 months. And the primary endpoint was disease-free survival, and the secondary endpoints included overall survival. And as you can see in the Kaplan-Meier curve, again in red, you can see that for modified FOLFIRINOX, patients did a lot better compared to gemcitabine alone. where the median overall survival in patients with FOLFIRINOX was 54.4 months compared to 35 months with gemcitabine alone. The 3-year overall survival rate with modified FOLFIRINOX was over 50%, so 63% compared to 48% in gemcitabine alone. So what do we do in patients who have metastatic disease? In first-line setting in patients who have a good performance status, meaning that they're fairly independent, patients receive FOLFIRINOX. However, patients who have a performance status of 1 to 2, they get gemcitabine plus nab-paclitaxel. Patients who have a poor performance status would either get gemcitabine alone, and then gemcitabine plus erlotinib really appears to be more for patients who do not have a good performance status or have patients whose tumor does not have a KRAS mutation, which is approximately 5% of the patient population. So here's the seminal, phase 3 clinical trial showing that FOLFIRINOX was superior to gemcitabine. On the left, you can see the overall survival, where the median overall survival for patients who got FOLFIRINOX was 11.1 months, 1 month, compared to 6.8 months with gemcitabine. And on the right, the progression-free survival was 6.4 months compared to 3.3 months with the gemcitabine arm. In patients with up to a performance status of as much as up to 2, but usually 0 to 1, patients who got gemcitabine plus nab-paclitaxel had a median overall survival of 8.5 months compared to 6.7 months with gemcitabine alone. It wasn't until recently that there is second-line combination study with 5-FU and nanoliposomal irinotecan in the Napoli-1 study. So here, patients with metastatic disease who had progressed on gemcitabine-based chemotherapy were randomized 1:1:1 with either 5-FU leucovorin in combination with nanoliposomal irinotecan, or 5-FU leucovorin alone, or nanoliposomal irinotecan alone. And here, basically, what on the left, you see that patients who received in orange, patients who got liposomal irinotecan in combination with 5-FU did far better compared to 5-FU alone. And on the right, patients who got nanosomal irinotecan alone did not do any better than 5-FU alone. So in the United States, patients who have progressed on gemcitabine-based therapy have an approval to receive 5-FU and nanosomal irinotecan. So, where does the future hold? There are multiple mutations that are being identified in patients with cancer, and their metabolic pathways. There is DNA repair pathways and oncogenic drivers such as NTRK mutations that are being used to target cancers in general. So using patients who have selected patients who have a BRCA1 or BRCA2 mutation, there was a study that was performed. It was an international phase 3 clinical trial in which patients who had these underlying mutations, who received platinum-based therapy combinations, and who had either stable or response for 4 months, were then randomized either to placebo versus olaparib, which is a PARP inhibitor. And it showed that patients who did receive a PARP inhibitor on the left had a improved progression-free survival compared to those who received placebo. Currently, there are clinical trials that are ongoing. They're also looking at somatic mutations, not only in the BRCA1, BRCA2 pathways, genes, but also in other homologous recombination DNA repair defect mechanisms, such as PALB2, ATM, etc. There are some clinical trials that are also combining chemotherapy with PARP inhibitors. Unfortunately, immunotherapy or immune checkpoint blockade with anti-PD-1, PD-L1, or CTLA-4 by itself has not been helpful in treating patients with pancreas cancer. There was a recent randomized phase 3 clinical trial which showed, randomized phase 2 clinical trial which combined gemcitabine and nab-paclitaxel either alone or in combination with durvalumab and tremelimumab. So targeting both the PD-L1 pathway and CTLA-4 pathway. And basically, as you can see on the right, there was no survival benefit in those patients that received chemotherapy in combination with immunotherapy. There are many clinical trials currently ongoing that are combining chemotherapy with immunotherapy and immunomodulatory agents that target the immunosuppressive tumor microenvironment. And there are many that are ongoing here at Columbia as well. So I think that we will end over here and then hold the questions for the end. Thank you.
Thank you so much, Professor Jankinger and Dr. Manji. Our third speaker and final speaker for the day is Dr. Vikram Chaudhary, who is an associate professor and consultant gastrointestinal and hepatopancreatobiliary surgeon in the Department of Surgical Oncology, Tata Memorial Hospital. His focus of clinical and research work has been gastric and pancreatic tumors, with particular interest and expertise in gastrointestinal neuroendocrine tumors and robotic and laparoscopic gastrointestinal oncosurgery. Dr. Chaudhary is the executive committee member of the International Hepatopancreatobiliary Association, India chapter. He has written more than 10 book chapters about gastric and pancreatic tumors. Over to you, Dr. Chaudhary.
Thank you. I thank Columbia University organizers for having invited me for this educational program. And Dr. Genkinger and Professor Manji have actually eased my task because many things they have already covered, and audience I think already has a fair idea about the management of these two cancers and their current status and risk factors. So I would like to touch upon a little bit of on screening, or maybe add few things to what Dr. Genkinger has already covered. So as far as the gastric and pancreatic cancers are concerned, India lies in a low incidence country. So India remains a low incidence country as far as two cancers are concerned. Most of our eastern countries have a very high incidence of gastric cancer, which include Japan and Korea and even China. And most of the Western population has a very high incidence of pancreatic cancer. Our cancer incidence in general, and particularly these two gastrointestinal cancers, the incidence fortunately in India has been low. However, over the last few decades, if you see, even this incidence has been rising gradually. So as far as the screening for these gastrointestinal cancers are concerned, usually the screening programs should involve the investigations which are easy to conduct. They should be non-invasive, they should be cost-effective, or they should be cheap, and they should be really completely non-harmful for the patients, or because these people are actually not patients, but the screening, when you conduct a screening in a person, that individual is actually most of the time disease-free. So it's like a vaccine, which should not have any side effects. So as far as the screening for gastric cancer is concerned, like most of the screening, the aim usually is to diagnose and treat the cancer at an earlier stage or even a pre-malignant stage, so that it improves the survival associated with the cancer or altogether prevent the development of the cancer in that individual. We know that 5-year survival rate of gastric cancer in Japan and Korea are more than 70%. And the same figures for America and even for India, around 20 to 30%. In our practice, around 10% of population operated patients have early gastric cancer. And the same figures in Japan and Korea are 50%, and now even they have reached 70%. So if you have a screening program which is nationwide, there are very high chances that you can detect the gastric cancer at an earlier stage, and which directly results in higher survival in these patients. And there is a definite benefit if you are doing it at a national level, at least in the countries where the incidence of gastric cancer is very high, or you can say that it is in endemic proportions. And now with the availability and development of endoscopic therapies, where there are non-invasive methods available for treating pre-malignant or early gastric cancer situations, the screening or surveillance programs or the investigations have more meaning, where you can actually do it in a very minimally invasive way in these individuals. Now, Dr. Genkinger has already covered, and we now know that there are acquired factors and there are genetic factors which result in gastric cancer in individuals. Most gastric cancers would be sporadic. However, around 10% of these cancers will have some familial or genetic syndrome component associated. Usually, there are dietary factors or smoking, and particularly H. pylori infection or a prior gastric surgery are the few acquired risk factors we should remember. And then there are few disorders which result in slightly higher incidence of gastric cancer in these patients. A particular mention should be made about higher incidence as per ethnicity, which happens in Japanese, Chinese, and Korean ethnicity, which is a little similar. And these people have higher incidence of gastric cancer, and their dietary habits also have something to do about it. So, a particular mention about H. pylori and gastric cancer. This organism has been blamed for for causing higher incidence of gastric cancer. Around 1% of H. pylori infected patients result in gastric cancer, eventually develop gastric cancer, and more than 90% of gastric cancer patients have associated H. pylori infection. So that is the correlation between H. pylori and gastric cancer development. And the most common mechanism by which H. pylori bacteria results in development of gastric cancer is causing the changes in the gastric mucosa. First, it results in development of atrophic gastritis, where few environmental and dietary factors help in that change. And then this first premalignant change, that is atrophic gastritis, gradually evolves into intestinal metaplasia, dysplasia, and ultimately the cancer. So our job is to diagnose these pre-malignant lesions in the individuals and treat it at that level, or even diagnose it before that level, so that you reduce the development of gastric cancer, or you treat the cancer at an early stage or a pre-malignant stage. So we all know that risk of malignancy increases gradually. So the atrophic gastritis will have slightly lower risk as compared to metaplasia, and the highest risk will be associated with dysplasia. There is a controversy about the age at which we should start screening. However, most of the countries where the national surveillance programs are carried out, the age of onset of screening is usually 40 years. The screening programs, as you know, H. pylori is directly associated with higher incidence of gastric cancer. The screening programs also should have a simultaneous program which takes care of H. pylori eradication. As far as the countries like India are concerned, which have a very low risk of gastric cancer, the screening usually cannot be recommended for general population, for practical purposes, and definitely considering the cost benefit ratio to an individual or the society. So the main question finally is, who should be screened, when we should we screen, how we should screen, and what should be the strategy on patients or the individuals who have higher risk of gastric cancer. So to summarize, the mass screening is only justifiable in countries who have a very high incidence of gastric cancer like Japan or Korea. Even China, I don't think, has a national screening program for gastric cancer, because you cannot actually do an upper GI endoscopy in a population of 1.5 billion. And that is a realistic problem even in a country like India, though we don't deserve a screening program for gastric cancer. And if not the whole population, there is a group of individuals who have high risk of development of gastric cancers, the hereditary syndromes which we mentioned. These are the individuals in which we can consider doing selective screening. So these are the hereditary syndromes which have higher risk of development of gastric cancer as compared to general population. And the most important mention should be made about the hereditary diffuse gastric cancer syndrome, where the lifetime risk of development of gastric cancer in a patient with CDH1 mutation is in the range of 80%. So it means if the patient has a mutation in him, there is 80% chance that the patient will eventually develop a gastric cancer over a lifetime. And these are the patients where even a prophylactic total gastrectomy is also considered. And it is usually performed when the patient is beyond 18 years of age. And in the patients who do not opt for prophylactic total gastrectomy, you can offer 6-monthly or 12-monthly upper GI endoscopy or surveillance in these patients. And there are syndromes like FAP or Peutz-Jeghers syndrome, or juvenile polyposis or Lynch syndrome, where selective guidelines for doing upper GI endoscopies exist for the screening of these cancers. Similarly, the patients who have been detected with H. pylori infection or who have already developed atrophic gastritis or intestinal metaplasia, these are the group of individuals where probably they can be considered for selective surveillance and H. pylori eradication. And when to screen, as I already mentioned, usually it's the age of 40 when the screening is considered, when it is offered at a mass level. So what are the investigations which you can perform for screening? So in countries like Japan and Korea, the most investigation of choice is a conventional upper GI endoscopy in few patients when they find doubtful lesions, and for their confirmation, magnification endoscopy or chroma endoscopy, which employs a dye, or a narrowband imaging. These are the additional investigations, or these are the adjuncts which you can use while doing endoscopy to further define doubtful lesions when they are detected on endoscopy. And there are non-invasive tests which you can consider in slightly higher risk population, or the populations who have slightly lower risk as compared to the endemic locations. And the pepsinogen levels and H. pylori serology are the two non-invasive tests which can be considered. They have their own limitations, and I think this is beyond the scope of this discussion. But there are limitations of these two investigations, being they're definitely not diagnostic, and the patients who will have, or the individuals who have altered investigations in these investigations, we may have to perform an endoscopy for confirmation. But these are also non-invasive options which you can consider. Obviously, the endoscopy is the modality of choice in endemic countries like Korea and Japan, and it is most accurate, and also provides for biopsy and even the treatment in these individuals. So the strategy finally for gastric cancer screening will be high risk individuals in a population with very high incidence, and there the investigation of choice will be endoscopy. And high risk individuals with low incidence countries, a stage screening approach probably would be required. And initial screening should focus on epidemiological factors, genetic risk, H. pylori infection, and probably pepsinogen and H. pylori serology. But to date, there is no cost-effective strategy which is available for average risk individuals in low risk population, and therefore gastric cancer screening is generally not recommended as a routine, at least in India or countries who have low incidence. To summarize, screening for gastric cancer enables detection of cancer at early and pre-malignant stages, which ultimately reduces morbidity and mortality associated with it. Mass screening and endoscopy is generally recommended only in countries who have epidemic proportions of incidence of this cancer. And in low incidence countries, only individuals with high risk for development of these cancers can be considered. And general population, the screening for gastric cancer is generally not recommended. I think most of the aspects of pancreatic cancer screening have been already covered in the Professor Genkinger's and Dr. Manji's talk. So I think I'll just summarize the screening for pancreatic cancer. So around 10 to 15% of pancreatic cancers are familial. It means there will be a first degree relative, two or more first degree relatives who will have a history of pancreatic cancer in a family. And then you can say that that is a familial pancreatic cancer. And out of these 10 to 15% of families, only 10 to 15% of these families will have an identifiable genetic mutation. One of the common genetic mutation which has been identified is inherited pancreatitis and BRCA. And we know about the risk factors. I think Dr. Genkinger has already covered. An active tobacco smoker is at a very high risk of is at a moderate risk of development of pancreatic cancer. Dry cleaning and metal workers have a risk of pancreatic cancer. Moderate or a low intake alcohol does not increase the pancreatic cancer risk. However, a heavy alcohol intake synergizes with smoking, and that really increases the risk of development of pancreatic cancer to a great extent. Chronic pancreatitis and diabetes have moderately increased risk of development of pancreatic cancer. However, recent onset diabetes and recent onset chronic pancreatitis are associated with slightly higher risk of pancreatic cancer. but probably they are considered as manifestations of pancreatic cancer rather than actual etiologic factors of pancreatic cancer. So if there is a familial trait which is identified in a family, usually the earliest screening which should be employed in pancreatic cancer is 10 years younger than the earliest case in the family. So that is one of the take-home messages for the people. And the most common investigations which are used in pancreatic cancer screening are endoscopic ultrasound and MRI. However, endoscopic ultrasound is an invasive test. And to summarize, routine cancer screening for pancreatic cancer is again not generally recommended in asymptomatic individuals. And that does not happen, I don't think, in any country that is followed. So routine screening is not done. So screening in familial high-risk individuals can be offered, and that has to be individualized. Endoscopic ultrasound being a non-invasive test and having a higher yield is the commonly suggested investigation, but MRI is a non-invasive investigation and it has the same efficiency. And so EUS and MRI are the two options which can be used when you decide to offer screening. Generally, for Indian perspective, a take-home message would be both these cancers do not deserve a mass screening, and that is not a routine practice in India. However, high-risk individuals and families would be offered screening at specialist centers if they have a familial trait or a familial syndrome diagnosis. Thank you.
Thank you so much, all three speakers. So we have some questions from audiences that I will put up and also ask some of my own. So I'm going to start with this point about, this national screening for India, which doesn't seem to be feasible in terms of what you said, Dr. Chaudhary, because of the cost, effectiveness, basically. Cost seems to be
also the incidence, actually.
And and based on the incidence as well. Are there regions, like Dr. Genkinger mentioned Chennai, so instead of a national strategy, and especially for gastric cancer,
I think I should have covered
a regional strategy.
Yes, so I should have covered that. So our northeastern population has an ethnicity which resembles China and Korea and Japan. And actually, Chennai, not only Chennai, even the northeastern states have a very high incidence of gastric cancer. And though it is not in endemic proportion, it is high. These are the populations probably where you can consider selectively, or maybe you can have a low threshold to perform endoscopies in these populations. That's what you can offer, at least in India. Yes. So yes, I agree. There is a scope of offering. It has been discussed, and there are few studies which suggest that northeastern population is the population in India where you can actually consider offering gastric cancer screening on selective basis.
Okay, thank you. And we have a couple of questions about H. pylori at the population level. So how can we implement this screen and treat strategy in a country like India? And I'll probably ask this to Dr. Manji and Dr. Jankinger. How do we, when we think about H. pylori, what is the screen and treat strategy for this at the population level?
But I think, I'll have Dr. Jankinger speak more about India and screening for here. When there is somebody who's H. pylori positive and comes with gastritis, it's routine that we go ahead and do the combination antibiotic and PPI treatment course, and make sure that they are eradicated for H. pylori. But I'll let Jeanine sort of speak more to it.
Yeah, in general, I think there is this idea that it would be beneficial. It's controversy about how beneficial it will be, and some of it has to do with the H. pylori, also thinking about the CAG-A gene, thinking about other pieces about its impact on gastric cancer risk later on, and also thinking about, are there other harmful effects if we eradicate in certain situations based on the timing. And I think the timing is pretty critical. It has to be obviously early enough that it has an impact on gastric cancer, because if it occurs after gastric cancer has already started to develop, then there is a belief it might not be as beneficial. But there has been so much research being conducted right now on the microbiome and understanding all the complexity there, that I think we still need to understand it better in relationship to gastric cancer before implementing something on a population level. But as Dr. Manji was saying, like if someone comes in and they test positive and are symptomatic and are, then that obviously makes sense. I think just thinking about it on a mass general population level, in a population that's not considered high risk for gastric cancer is probably not going to be the most cost effective, or it might not have the most beneficial effect. And we still have to fully understand what it means when we do eradicate it for what is the impact on other components of the body too.
But at least in
Yes,
India,
Dr.
when there is when there is an opportunity to perform an upper GI endoscopy, most of the gastroenterologists and most of the people who are doing endoscopies now, they are aware of H. pylori, and these tests are done as a routine when the patients present with upper GI symptoms, and at least in these patients, H. pylori eradication can be offered when it is detected. So that's what is happening selectively.
Okay, great. A question is, that's come up is about the, since you spoke about the gut also and the microbiome, looking at the diet, is the food in Japan and Korea, is the diet, if we think about the microbiome, does it cause a predisposition in any way? Dr. Jankinger, yeah.
Oh, with gastric cancer, I mean, I think a lot of it is concerns around salt and pickled foods and other concerns around the diet, the rates of smoking in that population. Those are things that can contribute to this. There could be some underlying genetic predisposition. So there's a number of factors that come together, and we just know that there's very high rates in some of these Asian populations that warrant doing sort of mass screening versus like when there is intermediate or lower risk, which would suggest not to do that in that setting because it's not as cost effective and it can lead to unnecessary effects from doing screening. And screening itself is not without its own risks, and it's trying to balance those risks versus benefits when we think about screening on the population level.
I'm going to ask a question about education and how in terms of India, where in terms of the medical profession also, how do we see gastric and gastro, just the basic syndromes, of pancreatic cancer and gastric cancer? Are we seeing a lot of hubs of students who are now specializing in these? Are we seeing beyond the Tata Memorial Center? Are we seeing more treatment centers or more doctors who are trained, and distributed nationally, or are we still seeing them only in the metropolitan areas? Dr. Chaudhary, what do you think? Yeah,
I think the things are changing since last decade. The qualified surgical oncologist and the surgical gastroenterologist and the medical gastroenterologists who are disseminated after training across the country have significantly increased. I think we have a significant availability of these specialists across the country. Obviously, there are areas and rural areas where the access is still a problem, but it is also to do with awareness and education and poverty, and there are many issues which can be considered. But as far as the access to healthcare is concerned, there is availability. But the problem is about the knowledge and the awareness. And I think that will also change gradually. As far as India is concerned, the priority will still be the secondary prevention or early treatment or at least a proper treatment access rather than screening and prevention, at least in GI cancers. Yes, there is availability, but there is lack of awareness, and poverty is also an hindrance.
So on the lack of awareness front, then, could you speak about efforts that that have been, very positive, either, a media campaign that you've seen or a website that you yourself have, been part of, or any activities that you yourself as people in the healthcare system and in this particular field?
The doctors at my institute, fortunately, we get opportunities to interact because many trust and organizations and social welfare organizations contact us, and we are involved in public awareness programs. Professor Chaturvedi from our department is a very active proponent of a anti-tobacco movement in the country. We every year conduct at least 3 social awareness programs. So we do our bit, and institute is involved in a lot of outreach programs. The institute has actually now expanded into multiple hospitals, and now we don't have only one Tata Memorial in Bombay, but we have at least 5 Tata Memorials in the country. and things will improve in this decade. Yes.
Great. And then from the, from the point of view of Dr. Jankinger and Dr. Manji, you can speak about either efforts that you know of or about, the efforts at Columbia University and the center to contribute to awareness.
Right. I think that pancreas cancer, even in the U.S., it's a rare disease, but unfortunately, it's a fatal disease, and very aggressive. Currently, it's the third leading cause of cancer-related death, and soon it's going to be the second leading cause of death. And the issue is that time is of essence to quickly, for diagnosis. So at the time, we cannot wait for delays in scans, and after you get a scan where you have an abnormal mass, to get an EUS where you can get the biopsy, and then another delay to get a surgeon, to get a medical oncologist and to start treatment. And because what happens is that there's a tremendous amount of cachexia and fatigue that is associated with pancreas cancer, and by the time the patients get diagnosed, within a month, their quality of life and performance status can be significantly debilitated, such that many patients don't even get access to initial treatment, and that is where I think that the general physicians and healthcare personnel need to understand that, so that patients can get quickly identify a specialist so that treatment can begin.
Thank you. And Dr. Jankinger, yeah.
Yeah, I mean, there have been a number of initiatives to better try to inform primary care physicians, which is, I think, what Dr. Manji and Shahari were just discussing. I think those are key because that's where most people are being seen. And can we better identify those high-risk individuals for the fact that someone presents with diabetes and they're thin, or they're showing up where they had an episode of pancreatitis plus recent onset diabetes? Can we better inform primary care physicians so that they know maybe we should look for someone's pancreatic cancer in that instance, even though it is rare, because I think it is very critical that we diagnose people as early as possible. I'm hoping through new research, we'll be able to better identify those high-risk groups and implement the screening procedures in those individuals, and hopefully use some as non-invasive techniques as possible. Can we use blood markers and other things that will change the game when it comes to thinking about these, so that only certain people will go on to get EUSs or MRIs, which can be, they're costly, they can be invasive, and really figure out who the right people are that we can get that, so we don't miss people as early as we possibly can.
Thank you so much to all three participants, and for your presentations. And we hope to continue this engagement on screening, and we hope to do this in person and not just virtually when Dr. Genkinger visits the center, and when Dr. Chaudhary and Dr. Manji can also be there. So our hope and our commitment is that we can hopefully contribute to the improvement of public health outcomes, and particularly in the space of cancer, and do our bit in spreading awareness and connecting people who might have symptoms and who might not have access to care, or who might not address these right away. So once again, thank you everybody, and keeping in the interest of time, we're going to close the panel now, and we look forward to our to welcoming you in January for continuing the dialogue on screening and diagnosis for cancer with the Herbert Irving Comprehensive Cancer Care Center. So thank you everybody once again.